Hello, everybody. It's really nice to have you all here. I have to sort of reiterate some of the things Lisa said about how much we believe in this idea of managing people with more than just one person. In fact, that's not good care anymore. And in chronic illness care, it really requires this idea that we are partners with our patient and their family, and that we teach them a lot about self-care and self-management, as well as provide them the kind of ongoing care that we're going to be discussing more today. So it's wonderful that we have this mixture of physical therapists, exercise trainers of all kinds, and mental health care professionals. And Lisa kind of touched on why we did that. And when I talk to you today, I'm actually going to spend I'm going to sort of frame this in this idea of physical therapists and exercise trainers, because I think some of the principles will be I want to be able to frame things so that those principles apply to exercise people. The mental health care professionals, you'll hear some things that are very important to you, but those will be expanded upon greatly when we move upstairs. Okay, so some of this you already know. Obviously, you're all seeing people with Parkinson's disease. You probably wouldn't be here, but just very quickly, we know that this is a neurodegenerative disorder that's chronic and progressive, and it can last a long time. In my practice, I have people that I've taken care of for over 25 years. As Lisa has really nicely stated, this has always been thought of as a motor disorder, but it's also a non-motor disorder. And to the point in the front row, some of these non-motor symptoms, which I'll review, are really becoming much more prominent and important, and should be recognized in a more systematic way as important parts of this disorder. This disease is all about disability, and that is what really constitutes quality of life. This is a very, very common disorder. We can look at it in a variety of ways. There are 60,000 new diagnoses every year. But the prevalence of this disease is growing because of our aging population. And I was reading a statistic to look at it a little differently than the way Lisa framed it, but there's going to be 147 million people with a chronic illness by 2030, and of those people, they will have more than one chronic illness. Half of them will have more than one chronic illness. So that's such an important comment, because this disease is not just usually seen by itself, but it's really set in a picture of comorbidities. And those comorbidities are other chronic illnesses which can have sort of an additive effect on what's happening with their disability. We see a fair number of people that are young, meaning under the age of 50, with this disease. And again, I think it's so important to think of chronic illness in terms of developmental life stage. Because when people are young and living a long time, they may have young children at home, they're working. It's a different disease than when you're retired and older. And it has a different impact on families as well. This disease really predominates in men. We used to think it's 50-50, but it's more like 60-40, and we have no idea why that is. We still, to this day, after all these years, don't exactly know the cause of this disease. We've certainly learned a lot more about it. We know that it is, that there are 10% that probably have a genetic explanation. And of that 10%, which isn't very many, we now know of 12 different genes that can contribute to this disease. And that's a lot of important steps forward. 90% are still sporadic, but probably more importantly is that this is an interaction between both the genetics of this disease and in some sort of environmental toxin, and also just normal aging. In the genetics world, we've learned that some people have genes for susceptibility, meaning, so if you and your brother both were in the same environment your whole lives, one of you may carry a gene for susceptibility so that when you were exposed to an environmental toxin, you would get it and your brother would not, if he did not carry that a susceptibility gene. Neurochemically, this is primarily a loss of dopamine in the brain, but there are also, we now know, many other deficits in other neurotransmitters. And I'll talk a little bit more about that. But we think that these other deficits explain more of the non-motor features than dopamine loss. The other thing that's become very, very, very important in the research of this disease is what we think of as a preclinical phase, meaning the phase before the motor signs appear. And those signs appear, the motor signs appear after the disease has been going on for probably 10 to 20 years. And there's a great deal of effort and interest looking at this preclinical phase, which is probably a triad, or not even a triad, but a combination of symptoms. One of the things that we know is that people lose their sense of smell years before they're diagnosed. And that's not specific to just PD. It can happen in Alzheimer's and other neurodegenerative diseases. But that coupled with a sleep problem called REM sleep behavior disorder, which I'll describe a bit, and depression, and maybe some other kinds of problems with sleep, may be a combination of factors that are suggesting that that person's going to go on to develop Parkinson's disease. So there's a lot of interest in this, because if in fact we could discover something that was neuroprotective, or meaning a drug that delays progression, and we also knew who was going to develop PD, we could actually give it to them before they got the motor symptoms. So a very important area of research, and one that's being intensively studied. The other thing that's very important for me to say to you, especially for the people who are thinking about exercise as their major intervention, is that the pathology is widespread in the brain and affects many, many other body systems. And this is just again, a schematic drawing of the brain, and also the areas of the brain that are affected in Parkinson's disease. But I think I have a, so if what we now believe, and this has been hallmarked by a pathologist named Hilo Brock and his wife, who's also named Brock, they started looking at the brains of people with Parkinson's disease, and they could see that this seemed to be an ascending pathology, starting in the brainstem and ascending to the cortex. And that fit very nicely with these symptoms of early stage pre-motor disease. So this idea of loss of smell, loss of problems with sleep, depression, all of these occurred before the motor symptoms. And we think that this is caused by a pathogen either entering through the nose or through the gut, and then ascending up the brainstem and depositing, causing destruction as it goes through the brainstem, finally getting to the cortex, where we have some of the cognitive non-motor symptoms that occur in this disease. The implications for those of you who are involved in exercise, in other body systems, is first of all the autonomic system. Again, if you think about involvement in this system and in the issue of exercise, you need to think that sometimes there's some problems with heart rate. It is not as important, though, as the problems we see with blood pressure. And I'm going to talk a little bit more about this, but the problem that people have is postural hypotension. So they might be, if you took their blood pressure and they were sitting down, and maybe some of you do that, their blood pressure might be fine. But when they stood up, the reflexes that constrict the vessels are altered, and they can actually have this delayed response of a vasoconstriction, and people can get very hypotensive. And especially if you're exercising and you're kind of fluid depleted, it makes you even more vulnerable. So we'll talk a little bit about how to manage that symptom. This disease involves the sensory system, and as you all know, the sensory and motor systems are very closely intertwined, and one of the overriding deficits is a lack of sensory perception. So when it comes to motor function, many people don't perceive this idea that they are short-stepped, that they maybe are not really perceiving where their body is in space. And so that's where this whole think big, exaggerate movement, big steps, big voice, all of the exaggeration of movement has come from, and it's this alteration in sensory perception. It also involves the frontal cortex, which is where attention and executive function, meaning the ability to plan and organize, is predominantly housed. And so in movement, those things becoming incredibly important. And I know that Faye Horak and Lori King are going to be talking a lot more about this ability to attend, to plan, and to organize as it relates to motor function. The temporal lobes are involved, which is part of the limbic system, and may constitute some of the symptoms we see with mood, apathy, and depression. So, and again, those are just all parts of the brain that do have an impact on what you might see in your particular focus of exercise. So how do we diagnose this disease? It's still very much a clinical diagnosis. People come in, they tell us their symptoms. We do scans primarily to rule out other causes, maybe a vascular cause, or I've even seen a presentation from a brain tumor looking like Parkinson's disease. But primarily it's a clinical diagnosis. I will bring up the fact that we have a scan on the market just recently called a DAT scan, and basically what that is it has an isotope that is radioactive, and you could actually see the dopamine uptake in the brain. And people say, well, why don't I get one of those? And it's, first of all, it's very, very expensive, and right now I think they're mostly useful when we're trying to really sort out two diagnoses. Not secondary Parkinsonism, which I'll mention, but really something like essential tremor. I have a patient right now who's got psychogenic symptoms of Parkinson's disease, and it's kind of an ethical dilemma whether to encouraging her to get this scan. What impact will that really have on her? Because her brain will probably look quite normal. And she's very attached to the diagnosis. So those are the kind of dilemmas I think clinicians are grappling with when it comes to the use of the DAT scan. Then there's when in making the diagnosis, in early stage disease, it's sometimes very difficult to make this distinction between idiopathic disease and a secondary form of Parkinsonism. And how many of you came to our Parkinson's Plus symposium? Did anybody come? Very, very good. Yes, so we touched on that in great depth. But and I'm not going to do that today, but I want to just, for those of you who weren't there, just mention some of the different categories of Parkinson's Plus. These are variants of Parkinson's disease or Parkinsonism, and the overriding issue is that they're very progressive. The life expectancy for most of these is maybe 3 to 8 years. So very different than what we see with idiopathic disease. The other thing is that they don't respond well to dopaminergic medication, and they desperately need their physical therapists and exercise trainers. So, you'll see these people for sure. There's MSA is one variant, multisystem atrophy, and it has the Parkinson's features, but it predominates with autonomic dysfunctions. So problems with their bladder, problems with their blood pressure, lots of problems with coordination. Then PSP, which is progressive supranuclear palsy, and again, Parkinson's features, but then they have this paralysis of vertical gaze. Imagine what that does when you're trying to walk downstairs, or problems with just being able to see the food on their plate. All kinds of issues that require good rehab intervention. And then they have severe problems with balance and speech and swallowing. Then there's corticobasal ganglionic degeneration. It's called CBD or CBGD. Again, this has the variants of it has the Parkinson's features, but it has this very unique factor of an alien limb phenomenon, where there's one arm that will actually do things without the person wanting their arm to do it. Might grab something. I mean, there's a lot of apraxia. It's really very, very disabling and progressive. And then there's the dementia with Lewy body. And we're going to be talking a lot about this upstairs in our mental health group. But I bring this up because there is this progressive cognitive decline in Parkinson's disease. And and in all Parkinson's disease, there are Lewy bodies. So this has become a bit of a controversial term. Nonetheless, some people develop cognitive problems early in their disease, like a year within the first year of motor symptoms. And in those people, they go on to, for the most part, to have a profound dementia and are the ones that get this this diagnosis. And that dementia is usually coupled with hallucinations and behavioral problems. So turning to the motor signs, which is what this disease is really all about. First of all, there's a resting tremor. Not everybody gets one, but about 60% of people present with resting tremor. And again, it's a resting tremor. So when they get ready to do things, their tremor gets better. So it's usually not as disabling as some of the other motor features. Rigidity is another feature, and this has implications for motor control in changes of posture, range of motion, a lot of rigidity of the dorsal rotation, which is so important in functional abilities. And then probably the most disabling feature, I think, is the bradykinesia slowness of the three cardinal features, that is. And what you see again in your interaction with these people are short steps, a decreased arm swing, decreased fine movement, and all kinds of, and the gait abnormalities. I've separated out coordination, although most of the time it's put in with bradykinesia, but it's so important to recognize that there is this lack of coordination, and it can be manifest as impaired turning, rolling over in bed, and that business of sequential movement, which you'll hear a lot more about tomorrow. And finally, although this is later in the disease, the postural instability, imbalance, and falls. As Lisa also said, this is much more than just a motor disease. It's truly a non-motor disease. And when we look at all the non-motor symptoms that a person can have, if you kind of actually, they're categorized in a variety of ways, but there's about 27 non-motor symptoms that a person can have. And on average, they've actually done these studies where they've counted how many non-motor symptoms a person has, and the average, so the average, not just when they add them all up together, the average is that people have 10 to 12. That's a lot of other symptoms. And these, by far, have a greater impact on quality of life, especially the cognitive and mood symptoms, than the motor symptoms. I wanted just one disclaimer. Some of that depends on where you are in the course of the disease too, because in middle stage disease, when you look at these studies by early, middle, and late, middle stage disease, the motor symptoms are causing a greater impact on quality of life often than the cognitive symptoms. And they typically, as I've said, don't respond that well to Parkinson's medication. Now, I'm not going to go through all of these, but I'm going to just show you how many there really are. And the ones I put in pink, I'm going to say a few more words about those at the end, how to manage them, because they do really, they do have an impact on what you're doing. So first of all, neuropsychiatric, look at all of those. Somebody asked about this: depression, anxiety, apathy, panic attacks, these compulsive behaviors that we call, they're now termed ICD problems, meaning impulse control disorder. And they seem to be caused primarily by the dopamine drugs. And the dopamine agonists, which I'm going to talk more about, Requip and Mirapex, are the biggest culprits. And these can be very disabling. Sometimes they are as simple as spending too much time on the computer. I thought that I had that problem yesterday. People have a change in behavior that their family recognizes, where they become just driven to do something they typically were not driven to do. The flagrant examples are hypersexuality, a change in sex drive that is very, very difficult for family members and often not seen as sort of a shameful thing, and so they don't bring it up. You've probably, the publicized things are excessive gambling and excessive shopping. So those have become an entity unto themselves. Psychosis and hallucinations. Then there's a host of autonomic problems: the postural hypotension, which I mentioned, urinary urgency and frequency, and we meet periodically with a group of trainers, which we'll tell you more about and hope you'll join us. But people who have urinary frequency and urgency in the middle of an exercise class, it's really an important and concerning problem. Excessive sweating, and then this problem with oil glands, where they can't get rid of the oil in their glands as quickly, and so it becomes sort of this itchy, scaly rash called seborrheic dermatitis, and then sexual dysfunction. There's GI problems, constipation, weight loss, excessive saliva, and difficulty swallowing. And then although sleep is not a body system, I've put it up here just so you can see the host of problems that occur. There's excessive daytime sleepiness. There's REM sleep behavior disorder, which, for those of you who don't know, is this inability to suppress the motor and actually verbal behavior of dreams. Usually our bodies are paralyzed during the dream period of sleep. And in Parkinson's disease, that inhibition is impaired, and people actually can act out their dreams. So they yell and they scream, and it can be severe enough that they hit their bed partner, throw themselves out of bed, and it becomes a safety issue as well as a real disruption for their bed partner. And they actually don't always know they're having it. There's sleep fragmentation insomnia, which is a terribly difficult problem for people, and nightmares, sleep apnea, restless leg syndrome, and I underline fatigue, because all of those of you who are involved in physical therapy or exercise recognize that fatigue is a very big limitation in performance. So energy conservation becomes an important strategy in thinking about when and what to do. It also has sensory symptoms. Pain is much more common than we have ever given it credit. And I'm going to say a word about that because it limits what people can do performance-wise. There are visual changes. People lose the ability for contrast sensitivity, so they can't see distinctions between color easily. And if you're doing anything in your classes, that's an important thing to make sure there's lots of contrast, lots of light. Loss of smell, as we've said, and there are some respiratory symptoms that also occur. So you can just see how many non-motor symptoms there actually are, and how many of them impact quality of life. I wanted to just talk about 3 different scales that we use to evaluate Parkinson's disease, because you'll see these referred to in all the notes that you get, and some of you do some of these scales. The first one is the Hoehn-Yahr. It's been around forever, and it is really a staging scale. And we still use it today because it's sort of part of the lore and care of Parkinson's disease, but it's only about motor symptoms. And I've just told you about all these non-motor symptoms, and yet it doesn't take any of those into account. But nonetheless, I think that's useful, because I think stage 1 and 2 are really, you can think of an early stage person. Stage 2 and 3 is typically a middle stage person, and 4 and 5 is somebody with late stage disease. And we talk about early, middle, and late all the time, and that's where this has come from. The one that's more useful is the United Parkinson's Disease Rating Scale. How many of you use this in your own practice? How many of you seen UPDRS score equals, have you seen that? Yeah. So what they're referring to here is part 3, the motor exam. We often do this in our clinic visits, and it gives you sort of an idea. It's one small objective finding to be able to compare to the prior exam. And of course, it matters whether the person's medication is working or not working, and I'll mention that as well. There's a new version of the UPDRS with an inclusion of the non-motor features of this disease in part 1, looking at those and how they affect activities of daily living. Part 2 are the motor aspects of activities of daily living. And this scale, although we use the motor scale, is more sensitive to change, actually, than part 3 in other kinds of earlier stage disease. Part 4 are then the motor complications of dopaminergic therapy, and I'll tell you a bit more about that. The third scale I want to bring up, this is not used as widely, it's becoming much more widely used through the National Parkinson's Foundation across their centers of excellence. But this is a caregiver strain score, and we gather this on data on all our patients as they come through clinic if they have a caregiver with them. It's so important because this is a family disease. It affects families as much as it affects the person, just differently. And so we really use this. It's 18 questions. It's called the MCSI, the Multidimensional Caregiver Strain Score. And for people that are 30 and over, we try to refer them to some sort of mental health care provider. We used to have a social worker. Sadly, we lost our funding for that, but we do try to make that referral because those people are experiencing significant strain. And sometimes, no matter how sensitive you are and how tuned in you are to your family, as a clinician you miss that. And partly because they're putting on the good face, because after all, they're not the one that's sick in their minds. So we find this a very, very useful scale to use. So now turning to management, and we'll have time for a lot of questions at the end. But there have been some actual studies where they have asked patients, what is it you need most in the care of your Parkinson's disease? And the number one thing is information and communication. And I think that's really an important comment. In chronic illness models of care, there's a great emphasis on truly this, it's becoming sort of a trite word now, but patient family-centered care. And what that means is that you listen to your patient and their family about what they need. And sometimes it's really quite different than what you think they need. But it's so essential. And it should be the filter that goes through all the different healthcare providers that see that person. And that there is a coordination of care around those requests. And more than that, that the patient and their family become participating members of the decision-making process, and that you really train people in self-management, because they are the ones that are going to be the most important manager of their disease. I like this analogy in that having a chronic illness is a lot like flying a small plane. And it's tricky and hard to manage, but if you master the skill of flying the plane, you land where you want to go, and you get to places that you might not have gotten to before. And if the patient and family are the pilots, the healthcare providers are really, they're only in the plane maybe a couple hours a year. And yet, so if you just think of it like that, they need to be the ones to really ensure that their patients are the best pilots of their own disease. So I think it's very descriptive, and I've always, I like that analogy. The second thing they've talked about is they want management of their motor symptoms, which I think is interesting, since when we do these quality of life studies, it's the non-motor symptoms they cause such an impact on their quality of life. And then finally, the third thing is a team approach, which we've said many times. One of the underlying principles that help people feel empowered to be in charge of their own disease is this concept of neuroplasticity. And I know that both Lori and Faye will be talking a lot more about this, but we used to not really believe that the brain was malleable, that it could change. We used to think, in fact, I can remember telling patients, my message of hope to them was that I hoped they had a slowly progressive form of the disease, rather than now being able to say what we can say now, which is that you can make a difference in your own disease. You actually can change the course of this disease, and we believe that without reservation. And one of the most important ways to do that is through exercise, because we know that you can form new pathways, you can actually increase brain volume and make new cells. You can even turn on genes with exercise and other kinds of sort of brain fitness activities. So that is, I think, a very important message to patients that gives them a sense of control and what I think of is self-efficacy, which really means confidence. It may not mean they're doing it yet, but self-efficacy by definition is the confidence to feel that you can be in charge of your own disease. So treating motor symptoms, I'm going to touch on three things. One is this idea of neuroprotection, although that word is now being sort of not really a fair word to use, because it means a change at a cellular level, which we can't really see. But so we use the term disease modifying, which in essence means delaying progression, or perhaps we hope someday stopping progression of this disease. From a pharmacologic point of view, we still have nothing on the market that delays progression. We have a ton of research in this area, and in fact, I'm part of an NIH-funded consortium that looks just at neuroprotective agents. And we know a lot about mechanism. We know all these 7 different mechanisms that lead to cell death. And what we hope someday is that we'll have a cocktail of substances, sort of like what's happened in the AIDS world, where they now can take a cocktail of drugs that have turned their terminal illness into a chronic illness. And we hope that we can give people a cocktail of compounds to really address these different mechanisms to delay progression. Now, exercise is much more promising in terms of neuroprotection, and again, I'm just going to say that much, other than this slide is borrowed from Charlie Meschel, who's a basic scientist with us, and I think and he does a lot of work with rodents and a variety of aspects of Parkinson's disease, but really promoting this idea that there's a lot of evidence for the benefit of exercise and the benefits of exercise on mood, cognition, and mobility. And you'll hear a lot about that tomorrow and later today. So this slide, I'm going to try to break this down a little bit for you and tell you what's really important for you to know as physical therapists and exercise therapists. I'm not going to spend as much time for the mental health care professionals because Dr. Mack's going to tell you more than you could ever imagine knowing about the drugs related to the psychiatric and mental health issues of PD. So first of all, when somebody comes in to see us and they're newly diagnosed, we really, once again, patient-centered approach, listen to them about how their symptoms are impacting their life. And I can tell you, you can have two patients that when you do their exam, they look exactly the same, but one person perceives themselves as having a lot of disability and the other person thinks they're doing just fine. So it's really important to prescribe drugs based on what a person needs rather than what you think they need. That coupled with their age, the dominance of their symptoms, whether it's on their dominant side or not, and also the other sort of medical issues they might have and comorbidities. And also, I don't know if I mentioned what they're trying to do in life. As an example, I saw a young lawyer last week who was a trial lawyer, and he really had only a tremor. But you can imagine being a trial lawyer and having a tremor is quite disabling. Really different than somebody who is an artist and has a tremor on their non-dominant hand. If it was on their dominant hand, it might be a different story. So we really think about if we're going to just manage tremor, then, which is one of the first symptoms that we sometimes want to manage, we might use an anticholinergic, which are the Parsitan and Artane. Now, if you're seeing somebody on one of these drugs, Parsitan is a drug, its other name is erythropoietin. We get it out of Canada because it doesn't have as many side effects as Artane. The major side effects of anticholinergics that are concerning to us are impairment of short-term memory. And in a disease that already has this issue of cognitive decline, we are, and in an elderly population primarily, we're very, very cautious about using these. And in fact, with deep brain stimulation, the possibility of surgical control of tremor is much, much easier that way than sometimes these drugs. But that's a whole judgment decision and discussion with the patient and everything else about them. The two drugs at the top, Requip and Mirapex. Mirapex's other name is pramipexole, and Requip's other name is ropinirole. Those are dopamine agonists. They really stimulate the dopamine receptors. We often use these in early stage disease when people need a little bit more than they need a little bit more control with their slowness or their rigidity even, and sometimes even their tremor. The issue about these drugs are really their side effects. And I want to just mention a few of these to you because I think they impact what you all are trying to do. One is that they have a lot of difficulty with daytime sleepiness. They make people really tired. And we try to dose them at a level. We try to titrate very slowly and dose them as low as possible to prevent that side effect. The second thing is that for people who have any sort of cognitive issues, they can make those worse. Another problem. And the third thing is really they also affect postural hypotension. So if blood pressure is an issue, again, these drugs we might want to minimize or get rid of altogether. And the last thing, of course, is these impulse control disorders that we're always watching for. And then the second area is levodopa, our best drug to this day, been in the care of Parkinson's disease since 1968. How many of you have seen Awakenings? Yeah, most of you. Oh, fabulous. You know, it's really, that's what it used to be like for people. And so levodopa really changed Parkinson's dramatically. And it's a combination of carbidopa and levodopa. Carbidopa is an inert compound that just allows levodopa to get into the brain without as many side effects. And levodopa is turned into dopamine in the brain. And there's some controlled release formulations and immediate release formulations. And I'm going to talk about some of the long-term side effects which impact what all of you are doing in a minute. Rasagiline and selegiline are used in early stage disease. They have very, very modest benefits for motor control, and they block an enzyme that metabolizes dopamine in the brain. We use them. There's a lot of sort of controversy about whether rasagiline is neuroprotective, but right now it's only FDA approved for motor control, not for disease modification. The COMT inhibitors block another enzyme to allow the delayed metabolism of dopamine in the brain and the periphery, meaning outside of the brain, and those drugs are added on to levodopa to lengthen the duration of response. And finally, amantadine, its other name is Simitril. It's been around forever. We used to use it for early stage motor control, and now as we've learned more about how it works in the brain, we realize that what it's useful for is delaying dyskinesia. And dyskinesia is that involuntary movement that you see in many of your patients or clients that is caused from their dopamine drugs. You don't get dyskinesia without having a dopamine drug. So it's a drug to control a side effect of a drug, which doesn't sound right, but it ends up being what we do. So these long-term complications, and again, I think this is where Faye and Lori have added so much to the science of managing some of these problems, and it's been extremely, extremely helpful in our patient population. But first of all, as people are on levodopa or dopamine, usually a combination of these drugs, over time they'll start experiencing what we call wearing off. So at the end of their dose, they become they have more Parkinson's features. I use the word Parkinsonian, but I don't really like that word, although many people with Parkinson's disease use it themselves. But they develop more Parkinson's symptoms right at the time they're to take their medication, and we call that wearing off. So the take-home message would be, you should be exercising kind of at peak dose when your medicine's working best if you have this problem. And these wearing off episodes really follow the level of levodopa in the blood. The other one is what I've mentioned, which is dyskinesia, these involuntary movements. And they are typically at peak dose, although they can persist throughout the dosing cycle. The other thing, a little myth I'd like to dispel about levodopa is that many people come to us still and say, I don't want to start levodopa because I know that it only lasts for a short amount of time. And that simply is not true. What is true, it's almost like an optical illusion, because as you're on levodopa, and this is a progressive disease, more symptoms emerge on the same amount of medication you're on. So people feel like their medicines quit working rather than recognizing that they're having more symptoms. Because I can assure you, if you took the drug away, they'd have even more symptoms. The other thing is that there's a ceiling of that's dictated by the side effects of the drugs, so you can't just keep pushing up these drugs forever to compensate for all these symptoms. So it always works, and it's just, in fact, there's a few people in the world that we feel like it no longer is useful, but for the most part, levodopa still has an impact. Freezing is the other major issue. This is, as many of you know, is a hesitation or of movement, especially on initiation of movement. It can be gait. I've seen it in swallowing. I've seen it in writing. It's this freezing episode that's momentary, and we're certainly learning more about that as we study the brain. And dystonia is, by definition, a persistent muscle cramp. So you see dystonia with a posturing of the limb. You see people as they're walking, they might posture with their hand. I have a patient who every time she combs her hair, her other arm goes up like this, and she's like, oh, and not even really recognizing that she's doing that. So these dystonic features can occur at the end of dose, so they can be an off phenomenon, or they can occur at peak dose, so they're sort of part of this dyskinetic picture, and often more prevalent in young people than older people with the disease, and can be very painful. Now I want to just, this is just a video Jay and I took of this guy in 1999, that just goes to show you, and we show it a lot because I want to just show you, this is a person who is off his medication, and you can see his Parkinson's features, and then we've given him an infusion of levodopa. You can see these bandages on his arm, and you can see the change, and this is really what we see in this sort of wearing off or this on-off phenomenon. You can see the short step, the flexed knees. He gets to a doorway, he freezes. He does some strategies. He really does sidestepping, trying to take a big step, get through the doorway. He's talking to himself. He's doing verbal cues. They're not working. Trying to unweight. And now look at him. So you can see it. It's like Jekyll and Hyde. I mean, he'll even, so we asked him to, he's feeling frisky, to be sure. But isn't that something? I mean, so you can see, for people who don't understand this disease, they can actually think somebody's malingering if they're not trying hard enough, or there's all kinds of sort of emotional sequelae that can occur if you don't really understand that these are not, people cannot control these. To really minimize some of these fluctuations, we do all kinds of strategies. One is diet, because people who if they take their levodopa on an empty stomach, they get much more predictable absorption, and trying to keep it away from protein. And that's a whole lecture in itself, but our recommendation, if you're in with a client, you might ask them, and they're turning off, you might ask them when they took their medicine, and if they're, and if they take it, trying to make sure they take it on an empty stomach. Other kinds of environmental things really can make people more Parkinsonian or turn off, like infection. Medication compliance is probably one of the biggest issues. People are dosing many times during the day, and if any of you have tried to take pills multiple times during the day for the rest of your life, it's just darn hard. So you really have to help people develop systems for this. And, other medications block dopamine. There's probably the ones that are least recognized are the ones that have to do with GI, like Reglan. Some of them actually block dopamine. So sudden worsening can be due to that. Anxiety and stress can make people turn off more commonly. And exercise can either increase or decrease gastric emptying. So it depends on the individual. But whatever it does in that individual, it's persistent throughout that person's experience with a drug. The other things we do to rectify these motor complications or this fluctuation is give them drugs that lengthen the duration of the response, which I mentioned, shorten the intervals between their drugs so they're dosing more frequently, and what I've talked about in terms of when they take their medicine, utilizing exercise. I have some people tell me if I eat 3, what do they call it, pieces of candy and then exercise, I turn on quickly. And I'm like, okay, whatever it is, use it. But it's, people do really identify that maybe it's that that person responds to increased gastric emptying from exercise. DBS is a very important intervention for fluctuations, and I'll mention a bit more about that, and then I've already said something about amantadine. So in terms of your world, in moderate and advanced patients, it's very important to know that not only the motor but the behavioral symptoms can fluctuate with the level of dopamine. So people can have alternating mood problems, can become very depressed, despondent when the level of their medication is low. And they can look very different from hour to hour. So in terms of rehab and teaching, really trying to get people at peak dose, meaning an hour after their medication, is very important. DBS, just a quick word about this. We do a lot of DBS. It's a very important intervention for people. It's not for everybody, but the symptoms really respond well. It doesn't change progression, but it does set people back on the curve. So the disease continues to progress, but it helps fluctuations. It does not help balance. It does not help swallowing, and it does not help speech. And it can help dyskinesia. And people who have cognitive problems, we try to avoid doing DBS because there is some belief that it makes cognition worse for those who already have cognitive issues. And it's essential to have a caregiver. Another vote for caregivers. People who get DBS without a caregiver have a very difficult time managing all the issues surrounding that. And I don't need to say anything about rehab because you're already there, and other than our goal as clinicians is to refer to exercise therapists, to PTs and other modalities early rather than late. And that is a change, but a very important change, so that we can be more preventative in the limitations of this disease. Now, a bit more explanation. I still have 20 minutes, so I'm going to just take a few minutes of these three and then some time for questions. So the first, a word about cognitive decline, the kind of problems you'll see, because this is going to have a lot of implications for what you end up, how you end up managing people with, in your particular specialty. I mentioned postural hypotension, some things we do about that, and then pain. So it used to be, so people always ask us, am I going to become demented? So very difficult question. And what we know, we used to say 20 to 30% of the people have dementia. But there's been a number of long-term longitudinal studies over many years, and people very carefully characterizing their cognitive complaints, and it looks like about 80 to maybe 90% of people end up with cognitive decline. What's important is it's a spectrum decline, and that some people, have just more memory problems, where other people have global dementia. So, but the types of dysfunction that we usually see are, one, attention, so all this frontal lobe stuff that includes executive function that I've mentioned, where they have trouble planning, organizing, and sequencing. Speed of processing. So you're talking away, you're normal, but their ability to process your information has really slowed down. So to take it and store it and then retrieve it, they need to actually get it in there. So it's really important to try to do one thing at a time with these people when you're trying to give them instruction. And then this business of visual spatial, that the perception of their body in space is sometimes altered, and that can be really important for exercise. We do use these drugs that are used in Alzheimer's disease with only modest improvement, but we do use Aricept, Exelon, and Reminil. We use strategies of reduction of Parkinson's medicine. We try all kinds of non-drug therapies like cognitive stimulation, cognitive retraining, which we rely on very heavily with our speech language pathologists. And again, trying to think about energy conservation and really working with families and how to manage cognitive problems in terms of verbal cueing, external cues for like written strategies. There's all kinds of things that can be done to help people. It not only is it a problem in their just day-to-day management, but their self-esteem takes such a hit. I think the most common thing I hear is, I've lost my confidence to do blah, blah, blah. And when you lose your confidence, you start losing many of your abilities that you have simply because you don't feel like you can continue to do the things you used to do. So it can be a very sad and vicious spiral. Postural hypotension. I think it's important to realize that it's not all just lightheadedness. Some people describe this postural hypotension by saying that they feel more fatigued, or their vision isn't as clear, or they feel like they can't think as well. And often you can trace that back to really their blood pressure. There are meds that cause a lower blood pressure, as I mentioned, dehydration. So when people are exercising, really, if they have this problem, I really encourage them to use their TED stockings to be well hydrated. And sometimes we even treat them with the medication Florinef, which actually retains salt in the blood, and water follows salt, so they retain a circulating blood volume better. And then I've mentioned most of these things. So many people have hypertension. The other thing we see is that people develop postural hypotension because of their levodopa and their other medications, and yet they're still on their antihypertensives because their PCP doesn't really recognize this. So again, one of those falling through the cracks of multidisciplinary, multimodal care that we try to maintain the communication between all providers. The other thing I might tell you is that blood pressure is always lower at peak dose. So if you took a sitting and standing pressure right at end of dose, it would be quite different than it would be 1 hour after their dose. So don't let that fool you. Again, a word about pain. Very common, and although there are many different kinds of pain, the musculoskeletal pain is the biggest problem, and we try to treat pain with physical therapy, with exercise, with non-steroidals if we need to, so that people do not let pain be the problem that limits them from exercising. And especially if they have a comorbidity of arthritis or some other orthopedic problem, it's very important to factor that into whatever you're doing with them. I guess the only thing I didn't mention here was Botox for dystonia. We use Botox injections for dystonia, which can be extremely helpful for pain control. And also, we have some people that actually have neck dystonia, and they have their neck out like this. And you can imagine what that does to your posture when you have a balance problem. So again, all these different things are really important to put into a total picture of care for these people. So in closing, the core aspects of a really quality team is, first of all, doing what you're doing, is understanding all these complexities. It's kept my attention for a lot of years, and it never quits being challenging, interesting, and rewarding. Understanding and really utilizing the unique contributions of all the different disciplines and accessing them appropriately. And the only way to do that is to know what they do and who they are. And then putting, again, the patient and family in the center of your care and really developing good communication on an ongoing basis, not just one moment in time, but really learning how to communicate well, not only with the patient and their family, but other members of the team, and really knowing what your community resources are. Because in terms of healthcare and chronic illness, we can't really give good care without really utilizing our communities, because we can't afford to provide all of that through Medicare and Medicaid. So in that, I'd like to close and open it to some questions. We have a few more minutes before our break. Yes?
Is the caregiver strain scale appropriate for all chronic illnesses, or is that specific to Parkinson's?
So the question is the MCSI, the multidisciplinary caregiver strain scale, appropriate for all chronic illnesses? Or is it just PD? And actually it could, you should look at the questions on it, because I think it's not disease specific. And I think it potentially could be really useful in a variety of diseases. Faye.
Is there any evidence that the amount of dopamine you need goes up or down with chronic exercise?
So the question is, do you need more dopamine with chronic exercise, and meaning external levodopa? And the answer to that is, the answer to that is yes. It's never been studied totally completely in a very scientific way, but it's certainly our clinical impression. People tell us over and over again, you know, when I exercise, my medicine, I feel like I use it up, or it wears off more quickly, or whatever it is. And I think so. Dopamine's very important for motor function. So I think it makes very logical sense, and there's a lot of clinical evidence. Yes?
Is that a result of them metabolically, because they're metabolically more active when they're doing exercise, the medication is taken up more, or because their exercise in the body requires more dopamine from the brain?
So
know?
the question is this issue of needing more external or levodopa, more medication when exercise, is it a metabolic issue, or is it that the brain's just using more dopamine? We don't, I suppose we don't really know scientifically, but we think it's because of just using more dopamine. The brain uses more dopamine. You can see the brain light up with motor activity. So we know it's being used more, so it might be that if there's a limited amount, that we reach that place where the person really notices they need more dopamine. Deborah.
You say, and I've noticed this with some of my clients, that the increase of urination frequency and urgency, will it lead to lack of bladder control and incontinence?
So a very important quality of life question, which is urinary urgency and frequency. Will that lead to total incontinence? And actually, some people do become very incontinent. But most people just have urinary urgency and frequency. So here you are in your exercise class, and everybody, you know that you want them to be well hydrated, and yet they have urinary frequency and urgency. I think what's really, so it's a wonderful teaching moment when you really instruct people, you know, you're going to do so much better in this class if you really hydrate, but hydrate, you know, 2 hours before you get here. Because when you get here, empty your bladder, and then we'll take another bathroom break in an hour, or whatever it is that works for them. But I think so to answer the question, I think that it's, again, important to put all these factors together and think about in your own environment how you would manage the problem. And some people do have incontinence. There are also drugs we use to manage this urgency and frequency, which are drugs that relax the bladder wall, so they don't have as many issues of urgency. And that's another thing that I've done with a number of people. They say, I go to my exercise class and I have to go to the bathroom immediately. So we take their antispasmodic medication. We kind of place it in the day an hour before they go to their exercise class. Again, another strategy when you're really listening to your patient and understanding all the things they want to do in their day. Any other questions? Yes?
I'm curious as to what brain structure is stimulated with the deep brain stimulation.
So the question is, in deep brain stimulation, where is the anatomical target in the brain? And there are two right now that are used. One is called the globus pallidus interna, GPI, and the other one is the subthalamic nucleus. And they're both used, and we kind of make the decision depending upon what symptoms the patient's having. I must tell you that I end up choosing GPI most commonly now because there's more and more coming out about sort of psychological sequela of using the STN. That's not completely proven, but if all else is equal, I choose GPI more. And that is a swing from what we used to do. We used to do all STN. Yes?
Has the way that you refer to like physical therapists and speech therapists changed at all with the advent of the Medicare cap? And how have you guys integrated that into your team approach?
So it's such an important practical question, and wish I didn't have to think about it, which is, have we been affected by the Medicare cap in how we refer? And so I have two thoughts about that. One, in our setting, we don't care. I mean, we don't think about it because we let our therapists tell us, and they are really good at saying, you know, I'm going to see this person X number of times for this because I know I only have this number of times later on, and I want to use those later. You know, so they really titrate that. I think out in the community at large, it's a bigger issue, and that kind of forward thinking isn't as common. And I think we need to educate other providers about how to refer and how to manage those refers so they get the maximum amount that they need in a year out of their physical therapy visits. Yes?
Parkinson's does not seem evenly distributed geographically or demographically. Can you address that at all?
Actually, that's been a real quest in epidemiologic research, especially trying to look at rural areas where there's herbicides and pesticides, and is it more concentrated in those areas? And it's pretty well distributed, and certainly in metropolitan areas you see more of it, but there are more people. So it is pretty well distributed across the country. There's a little bit of uptick in places with well water, but again, we haven't been able to sort that out, and part of that is just controlling all the variables, and epidemiologic research is impossible. So again, it's a whole nother sort of barrier to really figuring that out. Yes?
You mentioned the pathogen entering the nose earlier, correct? And so is there any suspicion as to
What that pathogen is. So the question is questioning this idea of this dual hit phenomenon where pathogens can come in through the nose, in through the gut, and what are those pathogens? We don't know. We just really don't know what those are. Certainly a lot of interest. So many things have been looked at, but it's just so hard to control those kind of studies, so we haven't found the answer. Any other questions?
Yes. In all the neuroprotective research, has there been much research into the increase of neuroplasticity, the role of diet as well as exercise? Some said retarding the progression of the disease, encouraging the brain's ability to adapt.
So the question is there in neuroprotective research, are there some dietary issues that might be important in disease modification? Correct? Is that and so in all this neuroprotective research, a lot of these compounds we've been looking at are nutritional supplements. So one that I'm doing right now is with creatine. So one of the mechanisms is the loss of energy production of the cell. There's a defect in the mitochondria, and we know that creatine actually is energy promoting, and so that's the theory behind it. And of course, there's a lot of animal work that's been done before we've been using it. very long study. We've got people in this study for 7 years. Another study that I've done is with coenzyme Q10. Actually, there were 3 studies that were done, and that ended up not showing any lack of disease progression. And that was, coenzyme Q10 is a powerful antioxidant, but it didn't show any, it was not different from placebo. I'm also been looking at this study was just in its first phase, but we looked at inosine, which is basically urate and turned into urate. And it was noticed that people who had low urate in their blood progressed more quickly and had earlier onset of disease than those that had normal urate. So there was this whole idea we could increase the urate in the blood and maybe slow the progression. And actually what happened so far, it's just a safety study to date, but in women, that was the little look in the small sample, that was true. So that study is going to be moving forward. Let's see, what else have we looked at? So we've looked at a variety of nutritional substances. So far haven't found anything that really makes a difference, but I think we will. Some of it's study design, some of it are how we look at endpoints and outcomes, but I do think some diet will prove to make a difference in this disease.